Great, brilliant. Thank you so much, Lee. And yes, good morning, everybody. Apologies, I was a bit late. I would like to say I overslept, but that definitely wasn't the case. Lee, that was really good. And I think there's a few issues that we managed to tease out there that I think will hopefully come throughout the course of the rest of the day. And that very much is sort of around the concepts of personalized care, and very much as well around peer-to-peer learning as well, and that kind of peer support aspect that these virtual group cancer care reviews will hopefully provide. Tom, would you have any objections if I shared my screen, if that's okay?
No objections at all, Deepak. Be my guest. I'll stop sharing at this stage.
Brilliant. Thank you. Okay, so next up on the agenda, I think, is around the NHS Long Term Plan and screening as well. So I'll spend about 15 minutes just touching on the both of them, because I think it really helps to set the scene and understand why we are where we are at this particular point. So when we talk specifically about the NHS Long Term Plan, it was something that was published in Jan 2019, and it really set out stretching ambitions and commitments to improve cancer outcomes and services in England over the next 10 years. And the key ambitions at that particular point were that 55,000 more people each year would survive their cancer for 5 years or more, and 75% of people with cancer would be diagnosed at an earlier stage. And I think early diagnosis is really key in all of this. The ambitions would hopefully have been delivered in a way that improved quality of life outcomes, improved patient experience, and also reduced the variation and inequalities that we know that currently exist. So what does that actually mean in practice? What does that mean for us in Mid and South Essex? So they really made a number of key proposals in this document, and most of these actually we are hopefully seeing coming to light at this particular point. So they focus very much on bowel screening, and they made it easier for people to do this by bringing in the FIT screening test rather than the original FOB test. One dip through your stool rather than filling out 6 windows. Okay, way easier. And their rationale for that was, as well as it being easier to do, this test would actually be responsible for up to a 10% better uptake by groups that were hard to reach, such as ethnic minority groups and deprived patients as well. So, and that was actually based on a study. So, you know, as well as it being easier to do, you're also obviously reaching those hard to reach groups as well. They implemented HPV primary screening for cervical cancer across England by 2020. And that's because it was seen to be more sensitive and more reliable than the liquid-based cytology. So the plan was that more women who were at risk of cervical cancer would be detected, and obviously then their treatment could be facilitated according to their situation to prevent the cancer developing. In addition to that, they provided extensions to the lung health checks that were originally piloted in Liverpool and Manchester. And across MSE, these have really taken these forward in Thurrock, which had one of the worst rates nationally for picking up lung cancer. And essentially what this involves is any patient assessed as being high risk of lung cancer would have an immediate low dose CT scan. And the reason for that is because the original trials that were in Manchester, that they indicated that 65% of lung cancers were diagnosed at stage 1 and 13% at stage 4, the later stage, compared to 18% at stage 1 and 48% at stage 4 before the trial. So you can see here that the trial clearly makes a difference at picking up lung cancer significantly earlier. And what that involved really was mobile CT lung scanners that you take to people in supermarket car parks, for example. And the plan was, like we said, identify more cancers quicker, and picking up a range of other health conditions as well, which includes things like COPD and really reducing the inequalities that exist in cancer outcomes. We've heard about primary care. Well, we'll be hearing about primary care networks, and they're going to be required to really help improve the early diagnosis of patients in their own neighbourhoods by 2023 and 24. And they really wanted to focus on a new, faster diagnosis standard from 2020. And really what that would do would be to ensure that most patients would receive a definitive diagnosis or ruling out of cancer within 28 days of referral from a GP or from screening. And so essentially what that meant was that patients that were diagnosed with cancer could begin their treatment earlier. And for those who aren't, it puts their mind at rest more quicker, following a very, very stressful time. Central to this, like we said, obviously are GPs and primary care, and I'll speak in the next slide about, briefly about the PCN DES, and we'll hear from Tom Wilson shortly about the exciting new rapid diagnostic service, and this is very much built on developing existing services for faster diagnosis, a more streamlined service, personalised care, recognition of frailty, but also 10 models that were piloted within Cancer Research UK that focused on diagnosing cancers where patients often present with what we call those non-specific symptoms, and they may go to their GP or their advanced nurse practitioner many times before they might get sent for blood tests or whatever. So within the next 5 years, RDCs are going to play a central role in the diagnosis of all patients with suspected cancer. And there may also be the possibility of self-referral for people with red flag symptoms as well. So as well as that, for patients with cancer, essentially what that will mean is quicker access to an accurate diagnosis, and again, hopefully beginning their treatment a lot quicker. And again, let's not forget that the majority of emphasis is to be placed on ensuring that those that don't have cancer, which is anywhere between 90 and 97%, get the support and faster diagnosis that they need as well. They also mention about increasing capacity of diagnostics, and that being key in all of this. And we're beginning to see the very early formation of community diagnostic centres and how these will really tie in with primary care. And incidentally, for any of those people that are interested, it really plans for primary care to be able to take on more diagnostics in shorter timeframes and be able to provide patients with diagnoses quicker. And it is all about the speed of diagnosis that I think is really key with the long-term plan. And I've popped a link to the article there if you're interested, and we'll share this presentation after. And with regards to the PCN DES, which again I'm very certain that most of you will know about, from the 1st of October 2020, it sort of spoke about the PCN being required to review and improve referral practice for suspected cancer, including recurrent cancers. And that can be done in a range of different ways, using clinical decision support tools, looking at own specific practice data, identifying safety netting and signposting mechanisms that are in place in practices and across the PCN. It could entail a nominated cancer champion that could be a GP, advanced nurse practitioner, nurse, GP trainee, auditing 22-week wait referrals for data present and any information that may help the triage process or the patient, and then completing an audit and feedbacking and completing the feedback loop on that. Also, as well as that, obviously contributing towards improving local uptake of national cancer screening programs, and I'll talk very briefly about some of our data across MSc. And as well as that, establishing a community of practice as well between practice level clinical staff to really help to support the delivery of all the requirements. And then from 1st of April this year, it was about PCNs being able to review and identify unwarranted variations in cancer outcomes. And specifically, that was for those hard to reach groups. And what can we do to reach patients in ethnic minority groups, those with serious mental illnesses, and patients with learning disabilities as well. And as well as that, PCNs will be encouraged to share.
Deepak,
yeah.
I don't think your slides are moving on.
Oh,
I don't know if anybody else is having problems, but sorry to interrupt the flow.
That's all right. Is anybody else having that issue? Let me unshare. Yeah. Have I just been stuck on the title slide the whole time? Oh, criminy. Yes. All right. Let me reshare.
We were all too polite to interrupt, though, Deepak.
Well, I did send you a text.
Oh, you did? Sorry. It's that thing. I can't do two things at once. You know that anyway, though. Right. Let me see. Can you see?
There you go. That's better.
Are they moving? Yeah.
Yeah.
Perfect. Brilliant. Okay. So here we go. So sorry, that was me coming back to it in practice. So just again, I spoke about bowel screening and cervical screening, extension of lung health checks, and the sort of significance in the data between the Manchester original study and sort of how key that is at picking up lung cancer at an earlier stage. Day 28 diagnosis and the PCN DES. Talking about the rapid diagnostic service, and obviously again community diagnostic centres there as well. And again, the early diagnosis aspect. So having spoken about the referral, practices and reviewing the uptake and improving those, national cancer screening programs, creating community of practices, variations in sort of cancer outcomes, and again for those kind of hard to reach groups, but also then PCNs being encouraged to play very much an active role in encouraging and facilitating the sharing of capacity for cervical screening across practices within network, and we've seen that happen as well. So this slide outlines some of the QOF indicators for cancer this year, and again, hopefully you can see some of the new particular QOF indicator there, which is obviously the percentage of patients with cancer diagnosed within the preceding 12 months who've had the opportunity for discussion and informed support available within 3 months of diagnosis. So 28-day diagnosis, and then following that within 3 months of diagnosis, obviously there is a new indicator there as well. So screening, I think this is probably the part where it's actually quite important for you to be able to see my slides, because there's lots of graphs and lots of tables, and it's really quite, and special thanks as well to Karen Hull for preparing this presentation and pulling together the numbers. And I think it's always really useful to be able to see the data and the numbers, so that we can really begin to understand where we are now and where it is that we need to get to. So going straight to it, hopefully you can see that table. So cervical screening age 25 to 49 and 50 to 64 with the associated deprivation scores. And so cervical screening, you know, and this is as of the 30th of October, so it's relatively up to date. It demonstrates a fairly good uptake in the 25 to 49 year age group, and an even better uptake within the 50 to 64 years. But we can see pockets emerging within our CCGs where there are definitely areas for improvement. And at first sight, you know, we've got Basildon, Brentwood and Castle Point and Rochford indicating or illustrating that there's no identified gap present to really achieve the 80% overall uptake. But actually, does this kind of show us the whole picture? And, you know, again, you know, the obvious question here is, where are the missing 20%? And I think, you know, as those within clinical practice, we're aware of the fact that we will never be able to reach the 100%. But it's important to try and think of ways that we can. And what I'm probably getting at is that our aim is not to achieve 80%, but to aim for 100. And our challenge is, how can we make that happen? How can we improve uptake in both age groups? And I think that's really confident for us to say that, are we doing everything that we possibly can within primary care? What is it that the data is not telling us about our cervical screening population? And, you know, what part do we play in this? And why is that all important as well? And, you know, what we do understand is, obviously, you know, whilst about 1 in 20 women will have a smear test which is abnormal, only about, I think it's about 1 in 1,500 will actually have cervical cancer. Okay, so that's quite important to note as well. Now, what is the data? What is that data not telling us? And I think this illustrates that. And again, it looks like a very busy slide, but actually when we break it down, what we can see is that we've got those two specific columns. So we've got the breakdown according to CCG, and then 2 specific columns. And then what we've gone on to do is highlight those tables within the hard to reach groups. And you can see that you've got patients with learning disabilities at the top. And so, you know, patients with learning disabilities, first of all, it illustrates that we've got a small cohort within that particular group. So the first question is, you know, do we have the confidence to say that we have recorded all patients with learning disabilities on System 1? And as you can see from this particular data, we've got 788 patients that are eligible to have had cervical screening, but only 422 have taken up the opportunity. So 46% of the learning disability population haven't participated. And so the obvious question is, why is that? And what can we do to support these patients further? Then you've got obviously the data set in the middle that illustrates the ethnic minority groups. And, you know, in total, 75% of patients have taken the opportunity to participate in cervical screening. And the uptake is higher within the age group, the 50 to 64-year-old age group. But how can we encourage the younger ethnic minority patients to actually come forward and participate in cervical screening? And then you've got the bottom table, which illustrates cervical screening uptake for patients with serious mental illnesses. And Mid and South Essex actually records on System 1 really demonstrate that we have got sort of a total of about 3,000 eligible patients with SMIs. 77% of those, so 2,300, have come forward. How can we really encourage the remaining 25%? 1 in 4 patients that are eligible for cervical screening aren't coming forward that have been recorded as having a serious mental illness. So what can we do to really help and support those particular patients? Again, this looks like probably quite a busy slide, but what these next 2 slides, what I'm hoping that they'll do, and again, I'll let you can look at these in your own particular time, but the key thing to note from both of these slides is across all age ranges between eligible patients and including those that are hard to reach, the blue line that you see going across the graph represents the national standard, and the red line really indicates where we are at MSE. And one thing that you may well notice is that, you know, consistently in a few of the graphs, the red line is falling short of the blue line. Okay, and so what can we do to really push for and encourage uptake? And that can be quite practice specific and demographic specific. But this is why engaging as a PCN is really good, because we begin to create communities of practice, and it's nice to hear what other people are doing as well. Now, moving on to bowel screening, the data sets on this slide are actually quite promising, aren't they? And we can see the blue line being the national average, and we can see that MSE sits comfortably above this point. This is both for the graph on the left of the screen, which is for all eligible patients, and the graph on the right, which looks specifically at ethnic minority patients. So whatever we are doing is working well. And again, it comes back to, you know, we can always improve further. But the next slide here really illustrates what we can do to really focus on this. And what you can see here is, again, the national standard for patients with learning disabilities and the national standard for patients with serious mental illnesses, and across MSE we are again falling slightly short of that. And this also may be compounded by the fact that, you know, as I mentioned in the long-term plan, Public Health England will be potentially lowering the age for bowel screening, just coming back to this, lowering the age of bowel screening in March 2022. And the aim is to really bring the age range down to 50 years of age. So you've got the 50 to 74-year-old. And this begins in MSc in March 2022, with the first phase of the programme really being a reduction to age 56 years of age. So I can really see this data set getting worse, because obviously we've got a much bigger cohort now to be screening. So what can we really do to help with that? And how can we ensure that we're reaching as many people as possible? And it may be things like displaying posters in surgeries and, you know, in-house screens to encourage patients to take up bowel screening, and making them aware of the fact that now at 56 years of age, you're going to need to obviously engage in the bowel screening process. And we can work very closely with Public Health England and make them aware of patients on our list who may have learning disabilities or serious mental illnesses. And what I'm hoping is that we can really establish communities of practice and see success stories nationally, work out what we can do to really reach these hard to reach groups. And then finally, the breast screening graphs. Now, a lot of caution needs to be applied when interpreting the results for breast screening on System 1, and that's because of the time lag that exists between primary care receiving the information from Public Health England and the manual entry required by practice staff into System 1. But really, PHE confirmed that the breast screening uptake is higher than indicated, and therefore this is not a fair representation, because you've got the blue line, which is a national standard, and you can see that, you know, across MSc we're significantly underneath that. But really, this is also compounded by the fact that routine breast screening, as we know, was temporarily paused from March 2020 to July 2020 for the pandemic, and then that resulted in a huge backlog of women that are awaiting screening. And then when they restarted the screening process, there was need for social distancing and infection control measures, and so, you know, we are constantly battling that backlog that they hope will be sorted by March 2022. But I would always, with breast screening in particular, I tend to look at these data sets with caution and interpret the graphs with caution. But, you know, one thing that we probably could take from this, and, you know, even if the data set was up to date, we would see that obviously patients with learning disabilities, patients from ethnic minority groups, and patients with serious mental illnesses would still be falling short of the national average. So again, obviously, you know, these are potential kind of measures to really think about. And again, obviously, you know, I'm certain that most of you are going to be doing these within your practice anyway. So working to time, take-home messages from this session. So we spoke very briefly about the NHS Long Term Plan and its focus on early diagnosis, as well as that, obviously, thinking about the screening changes, in particular bowel screening that is going to be changing from next year. We spoke a little bit about the PCN DES, and again, I'm certain that your practice is going to be doing all of that stuff, the QOF changes as well. But what I think is really, really good to look at is our own specific screening data. And again, thinking about those hard to reach groups, what can we do to really reach those, you know, those patients that are from ethnic minorities, those patients that have serious mental illnesses, and obviously those patients that have learning disabilities as well. Okay, so that just about rounds me up, I think, to be honest with you. Let me just stop sharing. And I think should we go straight into Emma's session?